Tonight, we're going to do rotator cuff rehabilitation, bring in some research, have a little conversation around rehabilitation. Ask any questions you want, put it in the message. I can't see it at the time, so my assistants will let me know when those come up, and I'll try to stop in the middle and talk about any questions that pop up. Just kind of want to chat around ways that I use BFR in the clinic to help with my rotator cuff rehab. If there's anything in particular that you're looking for, put it in the chat right now. And that way I can see it and I can make sure that I address it. You know, why spend the time to come in on a Thursday night? What is it that's interesting or you'd love to get out of this session? And then that way I can make sure that I provide that. I'll spend another minute giving you guys a chance to do that while we're letting other people in, and then I'll get started with the prezo. So my name's Ed LaCara. I'm the Director of Education for Smart Tools Plus. I've been so for about 10 years. My primary focus is, well, it's really overall wellness now. It's really evolved from musculoskeletal. I was a combat medic in the Army, and then then I was an athletic trainer, sideline, then I was strength and conditioning specialist. Went to chiropractic school, got a PhD in sports medicine, got an MBA, have had my own practice. And most recently, it's been more medical integration. So now my clinic in Dallas is really about the whole body wellness, functional medicine, primary care, pretty much trying to put the whole package together. But I still have a huge love for sports medicine. So that's why I kind of do these things and trying to really bring a different view on how we should be rehabilitating these things. So this is my contact information. Feel free to follow me on social. You can ask me questions on there. I'm pretty available. And either on my YouTube channel or IG, or just reach out to me via email. That's my work email right there. So happy to answer any questions that I can. So today, what I really just want to go through is have a conversation around how do we use BFR. I'll kind of answer what BFR is. Most people that are on these calls know what it is, but some people come on and they're fresh. So I always believe in teaching to the person that is attending that might not know as much as others. So I'm going to address like, what is BFR? Why do we use BFR, and why is it so powerful in the rehab space? And kind of talk about some ways that I utilize BFR, not only surgical patients, but my non-surgical. Something like 65% of the population over the age of 45 has a rotator cuff tear. So essentially, anybody that comes in my clinic that's over a certain age, I just assume that there's a tear in there. I've got to deal with that. And whether that's showing up as symptoms in the neck, or it's showing up as symptoms in the shoulder, or showing up as symptoms in the elbow or wrist, they can all go upstream and downstream. So these dysfunctions don't necessarily have to be painful in the area, but they can be causing problems both more towards the midline or proximal, or distal, more towards the hand. I commonly see that we really under stress the rotator cuff, and that's why the rehab is kind of inefficient, is that we can't progress the exercises fast enough, and we don't have enough time with patients to actually get true strength and conditioning through the cuff. And that's really where BFR sits, is BFR allows us to use very, very light loads, yet the body thinks you're doing heavy loads. So we're getting adaptation that really we wouldn't expect for months down the line after surgical rehab. And if we're just doing like like an irritation or tendonitis or tendinosis, I'm able to progress these people much, much faster using BFR, but using light loads, so that way we're not irritating the tissue. What you'll notice is that when I'm referencing research, you're going to see the articles at the end, but also at the bottom of the slide. So if anything is interesting to you, I would search and see, so you can get a better idea of what that study is and what I'm referencing. But this is pretty heavy in literature. I believe that what I should be saying should be research-based and evidence-based as best as I can. But I'll also throw in when I'm using this anecdotally, just in the clinic on an everyday kind of basis. So, you know, what the reviews, these kind of recommend is that we're using this biopsychosocial approach, which means I've got to approach my patients where they're at, meaning, are they early in their rehab? Are they in the middle of their rehab? Have they had a problem for years? How are they psychologically with their rehab? Where are they in that space in trying to meet them where they're at? So we want to try to build confidence in movements, because so many times we avoid movements because they hurt, and that just makes the problem worse, especially in the shoulder. The shoulder is the place where I see people baby their shoulder, and then all of a sudden a month down the line, now they have a frozen shoulder. Now we've got to deal with something that has progressed just because we weren't aggressive enough early on. So we want these rehab programs to be individualized and progressive, and we know that they need to last at least 12 weeks. So the literature really suggests that 8 to 12 weeks is a minimum amount of time that we need to spend on a progressive resistance exercise. And knowing that, I can set the expectation with my patients that, like, hey, this is just going to take us a little bit of time to get through it. When we look at what the cuff does, I kind of look at muscles differently depending on where they are in the body. So we have muscles that if I take my shirt off, and at 52, nobody wants me to do that right now, so I won't. But the muscles that you see, so in the shoulder, it's going to be my deltoid. That's what you're going to see, the anterior, the medial, and the posterior deltoid. Those are the movers. Those are the muscles that actually help my arm, my upper arm, my humerus move. And then you have the deep muscles, which are the rotator cuff. And the deep muscles, those are not movers, in my opinion, those are stabilizers. So the rotator cuff primarily is a stabilizer and thus should be trained that way as a stabilizer. The same thing would be if I was talking about the hip. You've got these big movers like the glutes, the glute maximus, big, strong muscle. You've got psoas in the front, big, strong hip flexor. Those are movers. You take my skin off, you can see those muscles pretty easily. The deep muscles, the P-go-go-Q muscles, the stabilizers on the backside are smaller, so they're stabilizers, and they need to be trained differently as well. And so we need to look at the cuff just like we look at the hip. They're very similar, and how we address it should be individualized to what tissue we're trying to repair or recover from, but they have to be looked at as a whole because they don't work nothing in the body works individualistically. It's all synergistic. God's not that dumb. Like we have the backups in the body, so we have to use them as a system. So when we look at the cuff, what does the cuff do? It helps to center the humeral head. The humerus is that bone on my upper arm. It tries to keep, so if this is glenohumeral joint, the humerus is sitting in that thing. And so what the rotator cuff is trying to do is keep that head of the humerus centralized or in the center, because then the muscles in the front, the muscles in the back, they're all at the same length. They're at a good length tension relationship. If I have poor posture, for example, and I'm rounded forward, then that humerus is sliding forward. That means the muscles in the front are shortened, the muscles in the back are lengthened, and those muscles are not functioning the way that they should, because muscles don't function well when they're either shortened or lengthened. They want to be in their optimal length tension relation. So we want the rotator cuff to stabilize. It supports elevation of the humerus. It improves dynamic stability. But with my overhead athletes, we got to remember infraspinatus, which is one of the 4 rotator cuff muscles, is stabilizing the arm or the humerus in overhead position. And so that's why we constantly see that with my tennis players, my pickleball players, volleyball players, that infraspinatus becomes the problem because of that overhead work. So we've really got to help identify where the problem is and how to address it, but treat them all as one big stabilizing entity. And so where the gap really occurs, that's me, by the way. That's my VA thinks that's what I look like, which is fine. Actually looks younger than me. We want to use heavy enough resistance to stimulate muscle growth or muscle hypertrophy and strength. But a lot of times we can't do that because the tissue can't tolerate that type of load. And so that's where we want to try to avoid pushing too early or trying to be too conservative too long, because we won't get the outcomes that we're looking for. So BFR allows us to use very, very light loads, but it's tricking the brain into thinking that we're doing very heavy exercise, which is really the cool thing. How do we strengthen tissue that's damaged without damaging it further? And so that's what BFR really allows us to do. And so BFR is blood flow restriction. It's basically using a cuff either on the upper arm or on the upper leg, and it's restricting blood into the limb. And it's not cutting it off completely, but it's cutting it off enough that it's creating what we would call a hypoxic, or a lack of oxygen into the tissue. And what that does is it makes the exercise much more difficult for that tissue. It also does some signaling systemically to your brain, like stimulating growth hormone and insulin growth factor and some other things. Basically, down-regulates something called myostatin, which doesn't allow myostatins in our body to prevent too much muscle from building, and it down-regulates that. So we get hypertrophy or muscle growth very, very early using BFR, like at 3 weeks, compared to what we would see with normal strength training, which would be more like 12 to 15 weeks. So we're able to use these cuffs in a very specialized way in order to trick the brain and the body into responding much earlier than what it normally would. So there's been lots of studies looking at this, and basically the efficacy is there. We know that BFR works. It's just about how do we utilize it at home and how do we utilize it in the clinic. And so, for example, this was a study looking at military cadets. They began upper extremity BFR at post-op week 6. So some people are very hesitant to use BFR prior to 6 weeks post-surgical because post-surgical patients in the orthopedic realm have an increased risk of deep vein thrombosis. And so even though there's no association, it appears from the research of DVTs or deep vein thrombosis and BFR, people are still very hesitant. So they might wait for a long time after surgery to start their BFR. Myself, and a healthy individual, I'm starting BFR day 1. You come to me the day after your surgery, we're going to do something with BFR because I'm not concerned about that based on the literature and my experience. But in this case, what they did is they waited 6 weeks. BFR was added to a standard rehab program for 6 weeks. And what it was trying to show is, without having to rely on heavy resistance, can we build muscle strength and hypertrophy or muscle growth? And what we saw was that, yes, it does. And it grows substantially compared to normal training. We saw meaningful improvements between 6 and 12 weeks post-op, and this was in external rotation strength, internal rotation strength, abduction, self-reported shoulder function, and pain and disability. So by combining BFR with our normal rehab, we were able to get better outcomes and also faster. And at 6 months, over 70% met reference values on 2 to 3 upper extremity performance tests, meaning it wasn't just a short-term benefit. We saw these benefits long-term, even 6 months down the line. So the 3 main ways that we use BFR are continuous, intermittent, and resting. And so I'm going to go through those because there is some confusion around this. So continuous BFR means I put the cuff on my limb. I exercise. Let's say I'm doing a bicep curl. I've got the cuff on. And then after my repetitions that I do, I'm resting. The cuff is still maintaining pressure. So the cuffs are on continuously. That's why it's called continuous BFR. I didn't make it up. Definitely not for brain surgeons. It's just makes sense. It's continuous. It's on during the exercise portion and it's on during the resting portion. And then we have resting BFR, which means, you can guess it, that the cuffs are only inflated during the resting portion. So I do exercises without the cuffs on. And then when I'm done with the exercise, I put the cuffs on. And believe it or not, you get very similar results with the cuffs on continuously versus resting. And it has something to do with the trapping of the metabolites from exercise seems to have this ischemic effect that physiologically allows us to adapt. The only problem with resting is it's very cumbersome. Imagine every time that you're finishing a set, you're now putting the cuffs on and re-inflating and then taking them off and re-exercising. So it doesn't really make practical sense. But we do use it in cases where people are not very tolerant to exercise. Maybe they weren't an athlete. They're rehabbing and they're just not used to lifting weights, and so they have a difficult time with the cuffs. I might use resting BFR. The other time that we use resting BFR is during sprint intervals. So I don't want to interrupt somebody's sprinting ability, like on a treadmill or on the field, because the cuffs are a little bit cumbersome. So I don't want to change their gait. So what they might do is sprints on a field, and then once they're done with the sprint, they put the cuffs on and we inflate them. And so that would be where we use resting BFR. And then we have something called intermittent BFR, which is where the cuffs are off during the rest period. Primarily, I use these for long bout walking or running. So people would put the cuffs on, they have the cuffs inflated, they go for a walk, but we only want those cuffs on for 20 to 25 minutes max. And so we're going to deflate the cuffs. And so they would have a deflation time during the rest period. And then they would go back out and start walking again and re-inflate. So 3 ways to use them: continuously, resting, and intermittent. And this is a really good graphic on how it's approached. 90% of the time, I'm using continuous BFR, meaning the cuffs are on during the exercise, they're on during the rest, and then between my sets, or not between my sets, between my exercises. So when I switch from a bicep curl to a tricep extension, the cuffs are deflated for a minute to give the arm a rest and to allow for blood flow to normally flow. Hopefully that makes sense. I'm going to take a second here and answer any questions. All right, Elena, I have 2 questions. For BFR for above cuff muscle, like the deltoid, does BFR help that muscle get stronger as well? How is the effect different from muscle below the cuff? Similar to glute if BFR for legs? Second question. Okay, so let me answer this first question first. So we're going to cover this in a second. We have 3 different effects from BFR. We have a distal effect from the cuff. Distal means away from the midline. So if I have the cuff on my upper arm, what is the benefit distal to the cuff? So that would be like bicep and wrist extensors and hands and all that. That's distal. Then I have proximal to the cuff, which is immediately proximal, which would be my deltoid, my pec, maybe my lat. And then I have crossover to the other side. So distal, proximal, crossover effect. You get an effect all 3 ways. The best effect is distal to the cuff. The second best is immediately proximal to the cuff. And the third best is a crossover. So if I'm working the shoulder, what I'm going to do is I'm going to pre-fatigue the distal muscles. So if during my rehab process, I might have somebody do some bicep curls, I might have somebody do some tricep extensions. And then after those 2 exercises, those muscles are fatigued. Now I go to my rotator cuff specific exercises, because now I have fatigued those distal muscles and I'm going to get better compliance or adaptation to the other muscles now that I'm looking at, the deltoid or the rotator cuff, because the other muscles have been fatigued. So hopefully that makes sense. For the lower extremity, what I would do is leg extensions, leg curls for hamstring and quadricep, and then do glute bridges if I wanted to really focus on my glute. Second question, can BFR do anything for scapular winging, causing impingement in the shoulder? Yeah, for serratus anterior, sure. I use this all the time. And normally when I'm prescribing exercise in the immediate phase, so what you have to understand about me is that nobody leaves my office without some sort of home exercise program. It can be day 1, you're 8 out of 10 pain. I'm giving you some sort of exercise, because we know that exercise decreases pain. So it helps me to rely less on medications, whether that's over-the-counter medications or it's pharmaceutical pain relievers or anti-inflammatories or corticosteroids. So I want to get people exercising and moving ASAP. So if I have injured tissue that's super injured, I'm going to have to do things that are away from that injured tissue. That might be doing things like something called reciprocal inhibition, meaning that I'm inhibiting the muscle that is aggravated by activating the muscle on the opposite side of the body. So an easy example would be if I have a hip flexor strain, like a psoas strain, I might do a glute bridge to try to neurologically relax the hip flexor or the muscle that is involved. I use a lot of serratus anterior with my rehab for the shoulder because the scapula needs to be stable in order for the rotator cuff to not be overworked. So I will put the cuffs on the upper arms and they will do push-ups with a plus, or they will do something that their arms are perpendicular to their torso, because that's where we see the most muscle activation with serratus anterior. I like TRX push-ups with a plus. I like push-ups with a plus with my feet elevated. Just any way that you can get that serratus anterior into a active motion. And if you can't, because it's too painful, then just do isometrics. We can always regress down to isometrics as a regression to stabilize. So that's what I would use for that serratus anterior muscle, that you're getting that winging, as long as there's not like, that winging is not due to some sort of like scoliosis or something. And even then, what are we going to do? If the scoliosis is there and you're an adult, I still got to train that musculature.
Thank you so much.
Oh, you're welcome. So Joe, I had a rotator cuff repair on both shoulders, both great surgeries with quick recoveries. Awesome. I use BFR as part of my strength work every week for 6 years. What I hope to learn is how to use BFR for help keeping the joint strong, stable, and mobile. Specifically as simple as doing my exercises that I do without BFR, but with lesser weight. Also, I compete in tennis tournaments all year as much as my work is similar. Okay, yeah. So we're going to talk about this next month, which is how to integrate BFR with normal high intensity exercise. Again, if you've been following me for a while, what you know is that I don't think BFR is the end all be all. I don't think that people should only train with BFR unless that's their only option. So if you can lift heavy weights, you should be lifting heavy weights at least once a week, and then supplement with BFR the remainder of the week to get your amount of volume that you need. So for example, like most of my weeks, I'm pretty busy. I have a high intensity trainer called an ARX, which is computerized resistance. I do that once a week. I do a full body workout on Monday. And then what I do is I'll do my BFR exercises on typically Wednesday, Thursday, Friday, because I give myself a little bit of a time off to recover. But I've done that heavy workout the first day of the week. Now you could program it any way you want. You could do the programming at the end with the heavy weight. You just need enough time off of that heavy intensity training. But I do think that if you are training, if you're able to train with heavy weights, you should. Now, if you can't, then BFR is a great alternative. And what you can do is you can alternate 1,000 different ways, no different than how you normally train, but you'll just use lighter loads, anywhere between 20 and 35% of your 1 rep max. Compared to when you're lifting heavy loads, that should be anywhere between 65 and 90% of your 1 rep max, because that's the definition of high intensity training. IT, 65 to 90% of your 1 rep max. Low intensity training is going to be anywhere between 20 and 35% of your 1 rep max. And then somewhere between 35 and 65% is going to be like medium resistance training. So low load training without BFR is essentially worthless. Why bother? You're not going to get physiological adaptation. There's nothing going to be there. So you've got to do heavy load training unless you're adding BFR to it. And then you just want to make sure you're not doing too much load or volume where you're injuring the tissue further. Melody's asking me, is 10 minutes max and is 2 times a day better? Not necessarily better. So it doesn't have to be 10 minutes max. It's, usually an exercise. So normally with a program, I'm going to write something between 3 and 5 exercises per muscle group per session, just depending on experience and where we are in rehab, or even just for fitness. 3 to 5 exercises is pretty much your max. After that, you want to throw the cuffs out the window because it's hard. Like BFR training is not easy. So 5 exercises max. It takes about 6 minutes and 40 seconds to get through a set of exercises. So you're looking at about 30 minutes. Now, if you don't have that kind of time, I think it's better to do one set, take you 6 minutes and 40 seconds, and then do another set of something else later on in the day, and then do it again tomorrow, and then do it again the next day. Anything is better than nothing. And so just depending on your time and your resources, then you do what you can. But no, definitely not 10 minutes is max. With aerobic capacity training, we'll do back-to-back sessions up to 60 minutes, because I do believe that we need to be training at least once a week at zone 2, which is probably a different conversation, for 60 minutes at a time, at least once a week, these long durations to prepare us for things like traveling to Europe and walking around, going to the mall, things that we need to do for longer durations. So you can definitely do things longer than 10 minutes. So I recommend it. Okay, thanks for the questions. Anything else pops up, throw it in there. Continuous BFR is going to be when we want to really focus on hypertrophy and strength. Intermittent, it's going to be, if you have less tolerance or you need to take a break during your rest periods. And then resting BFR is going to be just during the rest period, which is more like my sprint intervals. That's pretty much the only time that I'm ever using that. What makes the shoulder different? Primarily, it's that you've got these small muscles that really have to be working in sync. Otherwise, we lose range of motion. I also think it's different because of the way our posture is in everyday life right now, which is we're in this forward rounded posture, which takes my glenohumeral joint, shoves it forward. So notoriously, pec minor is shortened. My posterior, or the back of the cuff, is lengthened, and these muscles are not firing and functioning the way that they need to. And so we need to stabilize that before we can do anything else. And that's why I really like push-ups with a plus as one of my first exercises, even the acute phase, to try to get that normal centralization of the joint. So just a couple other studies looking at this. This was a Lambert study in 2021 looking at BFR with the shoulder. 32 healthy adults, 8 weeks of low intensity shoulder training with BFR. Did BFR with low intensity compared to low intensity alone. Just trust me, low intensity by itself doesn't create strength or hypertrophy. The days of your rehab being a TheraBand only should be long gone. Like, it doesn't work. We don't get stronger with that. And if you might get some muscle activation in the beginning, you might get some neurological changes, but you're not getting hypertrophy and strength. So we have to add BFR to those light loads if that's how it is. Otherwise, we've got to progress to heavy weight training in order to get the adaptation that we're looking for. And this study just demonstrated the BFR group had greater gains in muscle mass, in strength, in a bunch of different markers. We talked about this, distal, proximal, and crossover effects of BFR. So distal is below the cuff, proximal is above the cuff, crossover is on the opposite side. So if you just had surgery, so you come to me and you've had surgery yesterday and you're like, well, I've got this big brace on, I can't put a cuff on, I've got a cast on. I'm going to make you work the other arm because you're going to get a crossover effect to try to reduce the amount of atrophy or muscle loss and strength loss that you're going to get from that surgery. What people really don't realize is how much just the tourniquet alone from orthopedic surgery causes, I don't want to call it death of the tissue, but it's basically death of the tissue. If you see somebody's muscle mass the day before a surgery, and then you see it the day after, say, let's say like a anterior cruciate ligament repair, it is unbelievable how much muscle mass has been lost. And you got to say, well, it's not because it's been a day. Something else happened. And it's really because of the reactive oxygen species, the bad ones, that occur from the tourniquet. So we use BFR prior to surgery to prepare the limb for that surgical intervention. I recommend people doing passive BFR a week before they even have surgery to try to prevent the atrophy that occurs from the surgery and the tourniquet itself. So here's just some studies that you can reference looking at what happens proximal, distal, and crossover. But ultimately, we know that the goal is not just pain relief, but is trying to improve overall function. Again, another study looking at a 2017 from Popchak et al., looking at the different phases. And in the beginning phase, where we're trying to just protect the repair, then we're trying to restore motion and control. And then by phase 3, we're trying to rebuild strength, power, and sport readiness. This goes through a little bit of a talk around what kind of exercises should we be doing in the early phases? And, if we're adding BFR to these things, now all of a sudden you're getting a physiological adaptation that you weren't getting by just using light loads. So you'll notice these are light loads, or they're resistance tubing, but using the BFR. And then once we get into the heavy loading, then you can start to make a decision. Like, can I tolerate heavy loads? Great. Then use heavy loads. I can't use heavy loads yet, then I'll use lighter loads with BFR to get the same adaptation. What kind of exercises? For my physical therapists and strength and conditioning specialists and my athletic trainers out there that are doing rehab, you don't have to do anything different. There's no difference in the exercises I choose when I use BFR with low load versus just using my normal exercise protocol. You're just adding cuffs to your existing protocol. And you're making those light loads now be physiological adapting versus not. Nothing changes. Now here's another study looking at, this must have been a meta-analysis because it looked at 54 studies. Meta-analysis just means a summary of other randomized controlled trials typically. And so what it did is so it's looking at all 54 studies, almost 4,000 participants with chronic shoulder pain. They compared usual care versus using BFR. The main finding was shoulder-specific exercise therapy reduced pain, increased strength, increased range of motion. Another study, this is a 2024 study looking at hypertrophy and rotator cuff strength. I'm just kind of demonstrating that the literature suggests that by using BFR and light loads, we can increase strength, increase muscle mass without really adverse events or risk. So why does this matter? Well, a lot of people have shoulder problems. Like I said in the past, like 65% of the population over the age of 45 has a rotator cuff issue. And we need to be able to go in there confidently and start challenging the cuff in order to strengthen and adapt. I know when I'm older, I want to be able to lift my luggage and put it in the overhead in an airplane. And so how do I make sure that I'm able to do that 20 years from now? And that's going to be by strength training now. And if I haven't been strength training, then how can I use light loads to build myself up to be able to do those things? How many BFR exercises do you need? Anywhere between 3 to 5. 3 to 5 exercises in a session should be plenty. Programming is going to be different depending on fitness levels and where you are in your rehab process, but no more than 5 exercises, 35 minutes max. But what research has shown is that 2 to 3 times per week is just as effective as 5. So I typically don't program people more than 2 to 3 times per week, depending on, where they're at. Here's some exercises that you can kind of start with, low load options, side lying, external rotation, side lying adduction, all kind of the normal resistance to kind of tubing, resistance band, light dumbbell, all the same stuff that we typically do. And then we just kind of progress it. We kind of keep increasing resistance. We keep increasing the limb occlusion pressure, as we go. A good BFR shoulder exercise, technically clean, easy to coach, symptom tolerable, relevant to the current phase, scalable, hard enough to matter, and not so painful that it causes aggravation or inflammation or excessive pain. And, basically what you want to do is just get the shoulder tired. That's all that really matters, because once you get it tired, your body will adapt. So some key takeaways from tonight. BFR helps bridge the gap between protection and strengthening. It can help improve tolerance, control, and function. The right BFR approach depends on the rehab phase and the symptom level. Progress should be based on response, not time alone. BFR should support good exercise selection and not replace it. Next month, I'm going to be talking about integrating BFR with our high-intensity training. So just like I talked about before, I was also part of a research study at Jacksonville University where we did heavy intensity training with their football team on Mondays, and then we did BFR on Tuesday. We took Wednesdays off. We did high intensity training on Thursday. Then we did BFR on Friday, and I'll share those results with you next month. Again, there's my contact information. Very happy to chat, answer any questions. Here's some references from the weekend. I do have some other educational materials. BFR Bootcamp is a 5-day, hey, I need to get started and get going. It's about 1 hour per day of lecture, but you doing tasks to get you up and running in BFR. And then for professionals that need CEUs and want to learn and take a deeper dive into the mechanisms and all that stuff, we have BFR level 1, we have BFR level 2 for clinical and performance applications. And then I also have instrument-assisted soft tissue manipulation or mobilization available, all on this smarttoolsplus.com website. The certification is available through Smart Tools. All right. Feel free to follow me on socials. I appreciate it. A couple different cuffs that we have. Gen 3 is a cuff that's waterproof, so you can swim with this. It detaches from the hose. So we have a pump and Doppler built in to give you the pressures that you need. And then Gen 4 is app-based. That's the latest and greatest, where the cuffs are already, they have a pump built in. You just inflate the cuffs based on your app, and then exercise with the cuffs on. Those are not waterproof. So if you want to swim, get the Gen 3. And then just by being here, you get an educational discount on the Smart Tools website. Education 10 is the code. Feel free to use that for anything on our website so you can get a discount. Well, it's a fast 40 minutes. I'm going to stop my share and see if there's any other questions that I can answer. I try to keep these things at 30 minutes because I know everybody's time. Very valuable. So let me see. Wow, I had no idea there was a tourniquet that did that. Yep, Alina, it is a big part of that atrophy that occurs. Hey, Kadesh, can you discuss how to use the cuff in passive mode? Sure, absolutely. So passive BFR, so when it's passive, it means that we're not doing any exercise associated with it. What that normally means is that we're using higher pressures. So there's 2 passive modalities that I use with BFR. Number 1 is called a cellular swelling protocol. So if I have a patient that has a cast on and we don't want to lose muscle mass from using that cast, I'll use cellular swelling protocol. 5 minutes on, 3 minutes resting. So here you're going to just use intermittent BFR, 5 minutes on, 3 minutes off at about 60 to 80% limb occlusion pressure. And you're going to repeat that 5 times. And what this has been shown to do is maintain muscle mass. It's not going to build strength. It's not going to build muscle mass, but it's going to prevent atrophy during disuse times of being in a cast or in a brace for long periods. They also use this for people that are in comas or people that are bedridden to try to maintain their muscle mass so they don't atrophy away. The other passive mode is called ischemic preconditioning. We use this prior to high intensity exercise. Primarily, I only use this prior to Sprint intervals, I'll use it prior to, like if somebody has like a match, like I wrestled in college, so I have a big affinity for wrestlers. Like if they have something going on, like a 2-day event, like a track event, or you're using it prior to like plyometrics, something where you're going to get a lot of soreness. I can do ischemic preconditioning prior to that episode, and it reduces the amount of damage done from that exercise session or that training session. That's called ischemic preconditioning. Question for Melody: how does a power plate vibration fit into this? It can fit in really nicely. You can get a really nice stem cell activation with the vibration plate. You could put the cuffs on, stand on the plate, do some partial squats. You could get off the plate, do some push-ups, do some whatever kind of exercises you like on the power plate, but it's going to ramp up, and without having to use load. You're just going to use the power plate as your stimulus. What about, this is from Roger, what about using cuffs for recovery? Yep, absolutely. Recovery BFR is the cellular swelling protocol. 5 minutes on, 3 minutes off, 60 to 80% limb occlusion pressure, 5 rounds. You got to do at least 4 rounds, but 5 rounds are better. It takes about 45 minutes. And it's a nice way to recover from high intensity exercise. All right. Any other questions tonight? I really want to thank everybody for joining me. I know it's taking time out of your day, which is to me an honor that you would spend this time with me. We are starting a new community in Facebook. This is a Facebook community where people can ask questions. I will try to get on there at least once a day and answer questions and just be a resource. If you have any other questions, feel free to reach out to me on social media. Otherwise, I hope to see you next month where we talk about BFR in conjunction with normal training. And we will also kind of be talking about like different ways to program BFR along with your high intensity training. Thanks so much. Bye for now.